Hi, my name is L.Ingram. I'm a student at Charles Sturt University in the Foundations of Advanced Paramedic Practice program. This is for assessment number 3. This is a video of an advanced assessment on a respiratory patient. I am filming this with permission from the Northwest Pre-Hospital Care Program, utilizing their facility. And just to note that any of my assessments or any of my ideas associated with this video is not necessarily opinion of any other institutions, nor this one that I am associated with. So, just to begin, as a background, we have a patient with a respiratory dysfunction that we're going to assess in a bit of a scenario, and following the scenario, I will give a summation of what is covered in an assessment and all the other pertinent information associated with what I presented today.
So you were being called to a local long-term care facility for a 76-year-old male patient complaining of shortness of breath. It's 9:30 in the morning.
Okay, so I'm going to approach my patient, check my environment, and check my call, ensure that my scene is safe. I have a mechanism of injury. I'm assuming that it's going to be a respiratory or a medical issue. Allied agencies and patient-wise, there seems to be one patient at this time. And with regards to any sort of backup or transport, we'll assume that I'm in a personal response or an emergency response vehicle, so we'll need potentially a transporting vehicle. And then post-assessment, we'll see whether we need any further paramedics as well. I'll be walking to the scene. I'm going to make sure that it's safe. I'm going to do a look test of my environment, ensure that I can adequately assess my patient, plus to see if there's any PPE required or any other issues with regards to the environment. As I approach my patient, I can see this gentleman here. He is sitting on his bed. He looks like he's tripoding, maybe in a little bit of distress. Hi there, sir. I'm a paramedic. My name's Lindsay. How can I help you today?
I can't seem to catch my breath.
Yeah, I can see that you're quite short of breath and having trouble speaking with me. I'm going to keep my questions a little bit briefer for you so that you can kind of just keep catching your breath.
Okay.
All right, so how long has this happened?
Since last night.
Okay, perfect. So I can speak to the patient. He is speaking back to me. He's protecting his own airway. I do notice that he is having some distress and issues with breathing. He has about a 3 to 4 word dyspnea, which is an indicator of the level of distress that he's having. I'm just going to do, as I'm talking to him, just going to check for a radial pulse. I can assess the quality and the rate of that pulse. I'm also going to, obviously, as I'm touching him, look at his skin. Hi, okay, sir, what is your name?
My name is Pat.
Okay, hi, Pat. So you said that this just started for you last night, or it started to get worse?
Well, I've been sick. I was diagnosed with pneumonia. Just got really bad.
Okay, and how long ago was that? Do you know?
Oh, it's been about a week now.
Okay, very good. Do you have any medical history other than the recent diagnosis of pneumonia?
I have high blood pressure.
Okay.
A pacemaker. I got discharged yesterday, post-pneumonia from hospital, and I have something called COPD.
Okay, very good. And how have you been managing prior to this issue?
Fine. I just was sent back to the nursing home here. Said I was good enough to go back.
Okay, so I'm just going to do a set of vital signs here and an assessment on you. Is that okay, Pat?
Sure.
Okay, so can you tell me a little bit more about how you manage your COPD? Do you take puffers or any medicine for that?
I take puffers, and I do take medication, yes.
Okay, so you're going to see me, I'm just going to expose your chest here, and I'm going to take a look at how you're breathing. I'm going to look for any accessory muscle use that you might be using. I'm also looking at the rest of your body as I'm putting on my my leads here and assessing for any sort of cyanosis or anything that I see, any sort of pal or anything like that. I do see that you're starting to do some indrawing here on your chest, John, and maybe that your fingers are a little bit cyanotic. Do you ever have issues with needing oxygen with your COPD?
Not normally.
No, okay. So if I put on my monitor here, I've got oxygen saturation. I've got a ECG for lead 2 on. I'm going to put on a quick blood pressure cuff here as well to do your vital signs. Have you had a fever, John, at all, or Pat, excuse me, at all?
Yeah, I have, but not now that I'm aware of.
Okay. So we're just going to send this. You're going to feel a bit of a squeeze on your arm. I'm going to listen to your chest here, okay? Can you try to take some nice breaths for me? So I'm going to listen to all the APS and 6 spots here across the top, underneath, mid-axillary for any sort of adventitious sounds that I'm hearing, and then of course at the bases. Okay, so John, I can hear that you're having some wheezes and maybe some crackles down there in your lungs. Can you tell me what they told you at the hospital with regards to your pneumonia? Did you have antibiotics that came home?
Yes, I had some antibiotics. I came home with some.
Okay, very good. And have you been able to take those okay and got them started?
I just had one dose last night.
Okay. So what I'm going to do here right now, I see that your oxygen saturation is low. I'm going to put a little bit of oxygen in your nose here, okay? And that should help you. If you can try to take some nice breaths in through your nose, that would be great. And I'm just going to look you over a little bit further here, okay?
Okay.
So I'm just going to go do a quick head to toe here. I can see that his pupils look like they're equal and reactive. He's speaking to me, his airway's patent. I'm looking for any part of JVD here at the neck, kind of coming down. I see some accessory muscle used here within his chest. Do you have any abdominal pain or anything?
No.
No? Okay. What about pain in your chest, going back up to your chest here?
No.
No, you don't have any pain in your chest, you just feel short of breath, okay?
Yes.
Do you have any pain in your stomach at all?
No.
No, I'm just going to expose your stomach here. Just take a quick look, okay? Have you ever had any trouble avoiding your bladder or your bowel at all lately?
No.
No? Okay. And I'm looking at your hands. Do they seem swollen up at all in your wrists or hands at all?
No.
No, nothing like that. Do you have any pain or anything down into your legs here?
No.
No? And what about any swelling within the bottom of your legs here, Pat?
No.
No, you haven't had anything like that. Okay. So this pneumonia, you got diagnosed yesterday, is that correct?
No. Oh, about 5 days ago.
Oh, okay. So this has been ongoing, eh?
Yeah. Got back from hospital yesterday.
Okay. And you went to the hospital in between after being diagnosed?
Yes.
Okay, I'm going to do your temperature here, okay, just to see where we're at. And a blood sugar.
38.1.
Okay, 38.1. So your temperature's up a little bit here, and I'm going to do a quick blood sugar for you. I know you maybe don't have any problems, but we're going to just check that just to be thorough, okay?
8.0
Okay,
millimoles
perfect.
per liter.
So all of that seems to be within normal limits, okay? So with regards to your temperature, did you take any Tylenol or anything to try to, if you've noticed that you've had a fever?
No. Not today. No.
Not today, okay. So we're gonna make sure that you're sitting up straight here so that we can get your lungs open as much as possible. Just try to keep breathing in that oxygen, okay? Treatment-wise, I did hear a little bit of wheezes and a little bit of crackles in the bases there. I'm just going to do a few rule in, rule out things for you just to see if we can help you with some treatment. Is that okay?
Okay.
Perfect. So first thing I'm going to do is I'm going to do a quick test on your heart here just to make sure that you don't have anything going on. I see that you do have a pacemaker, but we'll do an ECG anyways. So this is a 12-lead ECG just to do a picture of your heart, okay? There'll be a bunch of stickers that come down through here. All right. And we'll check that out for you. Do you have any allergies to anything?
No.
No? Okay. And then do you have a list of those medications?
I can tell you what they are.
Okay, perfect. And other than the COPD, what else medical problems do you have?
High blood pressure,
Yeah?
pacemaker, and the pneumonia.
Okay, very good. Do you think that oxygen is helping you a little bit?
Not really.
No,
Still
it's
short
not,
of breath.
eh? Okay. Does it change at all with positioning or exerting yourself, your shortness of breath?
It's a little better with this position.
Okay. And if you walk around, does you get more short of breath?
Yes. Yes.
Yes, you do. Okay. And so that's been affecting you for a little bit here now. It hasn't improved with your antibiotics?
No.
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 Okay. All right, so I feel like we should probably take you down to the hospital. I'm going to recheck your blood pressure here. With regards to any sort of treatment with regards to your lungs, I'm going to try with a little bit of salbutamol that maybe we can open your lungs up a little bit. I did do a test on your heart, and along with some other history questions, I'm considering whether you have a cardiac issue versus this COPD exacerbation versus this pneumonia thing that's kind of irritating everything. And so with some of the testing that I've done and some assessments that I've done, I'm going to try to rule in or rule out a few things for you, okay, Pat?
Okay.
So I've looked at your ECG, and it looks like it's pretty good. You're in a pace rhythm. You do have a pacemaker, I understand. So
yes.
That's going to be a little bit undiagnostic minus some Scarbosa criteria things that we can look at, but it looks okay there. You're not exhibiting any chest pain per se. You don't have any peripheral edema, and you don't have any other complaints that maybe lead to you're having a cardiac issue today. So I feel like this is more of a respiratory thing for you. Treatment-wise, I think I'm going to start you with some Ventolin. If you take that on your own, is that correct?
Yes.
Okay.
Yes, I take Ventolin.
And have you taken much today?
I've taken 4 puffs,
You've taken 4
but
puffs.
hasn't helped.
It hasn't helped you. Okay. So we'll start you on some Ventolin. I'm going to start you on some puffs of Ventolin here, okay?
Okay.
And then just with regards to anything else, you know, if I listen to you, your back, or I look at your back here, do you have any specific pain in any areas of your lungs at the back?
No.
No, nothing like that. Okay. And did they do a chest x-ray on you?
At the hospital, yes.
They did. Okay. And did they say where your pneumonia was?
No.
No, eh? Okay. Very good. So we're going to start you on some of this treatment and then go from there. Do you have any questions for us or for myself before we go?
No.
No? Okay. So I'm going to start you on some of these treatments here, and then I'm going to reassess while we're waiting for the ambulance to come. So if you can take some nice breaths of this, okay? And we'll just keep going from there. Your oxygen saturation has come up pretty good, so that looks all right. Your work of breathing has come down a little bit, so that's good too. When you had your COPD, did they do any respiratory testing or spirometry or anything like that
Yes.
for you?
Yes.
Okay, and has there been a suggestion that you need home oxygen at all?
No.
Nothing like that?
No.
Okay. Okie dokie. And you've never had any issues with any swelling in your legs or anything like that?
No.
No? Okay. And sleeping wise, do you have to ramp yourself up with pillows, or are you okay
I did
for your
last
sleeping?
night.
You had 2 last
Yeah.
night, yeah. Okay. Are you coughing at all?
No.
No, there's no cough, so you're not coughing up any green or
No.
brown colored
Not
sputum
that
at
I've
all?
noticed, no.
Okay. So it's mostly that you're just short of breath. Okay. Have you ever had an issue with your COPD where you've had to be hospitalized at all?
No.
Nothing like that.
No.
Okay. Then you haven't had to have an intubation or a tube put down your throat to help you with your breathing?
No.
Have you ever had to have a mask put over your face to help you with your breathing? That's called CPAP.
No.
Nothing like that. Okay. Have you ever had anyone check your fingers to see if you have anything that's called clubbing associated with your fingernails?
Something was mentioned, but I don't remember.
Okay. So it looks like you do have a little bit of that, which is kind of an indication of some hypoxic issues that are going on. Have they tested your blood lately to do any sort of what they call blood
at the
gas?
hospital.
At the hospital. Okay. So what I'd like to do, if you don't mind, Pat, I'm going to do a few more tests while we're waiting here. I'm going to start an IV.
Okay.
And I'm also going to do a blood draw off your IV. And so from
Okay.
your IV, I'm going to use something called an iStat, and it's a nice little machine that we have here that we can look at a lactate to see how your infection is going. We can look at your electrolytes to see if you have an electrolyte imbalance. The biggest thing we can look at is your blood gas. We can see how you're doing with your carbon dioxide and your pH with regards to your respiratory status. And then I do have a fancy cartridge where I can really rule out, in the moment, cardiac stuff with the troponin I cartridge. So we're going to do all of those tests on you here now, if that's okay.
Okay.
Perfect. Do you see a doctor regularly, Pat?
Yes.
Okay. And so when you go to your doctor, do you have a specialist that you go see?
For my COPD?
Yeah, for your
Yes.
COPD.
Yes.
Okay, perfect. And when was the last time you saw the doctor for this?
Oh, about 6 months ago.
Okay, so are they aware that you've been diagnosed with pneumonia?
I am not sure.
Okay. So perhaps, a follow-up with that doctor might be something that you would consider as well, just to get some retesting done with regards to, your respiratory status after you've healed up from this pneumonia.
Okay.
And the dosing for your antibiotic,
Yes.
have you been able to keep that down? You haven't been nauseated at all?
No nausea.
No? Okay. Very good. And it was 5 days ago you had that course, eh?
Yes.
Okay. Did they do a blood test, to do a blood culture to see what it might be sensitive to? Do you know? Does that sound familiar?
I think they did when I first got to the hospital.
Okay. And there was no talk of a follow-up or any reassessment after the fact, eh?
No.
No? Okay. Okay, so we've got this all done for you here. So we're gonna get you to the hospital. Do you think you can come onto the stretcher when they get here? We
I
can kind of
think
help you
so, with
over? Okay,
Some help, yes.
sounds good. And how does that Ventolin make you feel? Does it help a little bit?
It's helping a little, yes.
Okay, So I'm going to do a quick reassessment on you here, okay, Pat?
Okay.
Okay. So I'm just going to listen to your lungs. If you can lean ahead, I will listen to you at the back here. Okay, good. Down at the bases here. Good. I understand it's hard for you to take big breaths there. You're doing really well, okay? Just try to focus on that breathing. So your pulse still feels good and everything else, and I can see that, you know, you're using a little bit less accessory muscles, so that's fantastic. You're doing really great, and nothing has changed further down here for you. Okay. So we're going to get going. I think it's best to go to the hospital to get this checked out, and then obviously have a good follow-up with your respiratory therapist and your doctor to make sure that you've healed up from this infection. I'm not sure if the antibiotic is working well enough for you with regards to clearing up that infection. You seem like you still have a bit of a fever and a few things going on. So I think going to the hospital and getting that looked at and that pneumonia re-looked at would be a pertinent thing. When you get there, they'll probably do some blood work for you. I'll give them my results as well. They'll probably perform a chest x-ray and maybe even some spirometry just to see where you're at, okay?
Okay.
Okay, we'll get ready and get headed to the hospital now, okay, Pat?
Okay.
So I just want to do a quick summary of the detailed assessment that went on throughout the simulation that I just exhibited. So basically, firstly, you want to go in and make sure your environment's safe. It's paramount that it's safe for you, your partner, and any other allied agencies that are coming into the scene. You're going to check to see if there's, what the mechanism injury is. You can get an idea of whether you're dealing with a trauma or a medical issue. How many casualties or how many patients that you have, if you have an MCI situation and you just have, again, like this situation, one patient in a long-term care facility. And then, of course, if you need any other agencies, whether you realize right away that you might need fire for an extrication or an ACP for some hands or something else, that is definitely consideration at this, initial point in your assessment. Do you need personal protective equipment? Just by nature of some of the call information, you might consider putting on PPE for this patient. You would definitely consider putting on a mask, a gown maybe, and a face shield with regards to COVID restrictions and COVID considerations and infectious disease processes as well. Is it cluttered? You want to look at your environment. So is it clean? Is it cluttered? What kind of things are you seeing around in the house or the place that you go into? Is there medical equipment that's associated with your patient? Are there medications lying about that maybe you could identify easily and quickly? Can your patient function within this environment? And so this is now a social thing that you kind of look for to make sure that that your patient can perform appropriate activities of daily living within their environment. You're going to see if you can adequately assess your patient within this environment as well, or do you need to remove them from the situation to better do your assessment and treatment. Your approach to the patient, you should approach your patient in a friendly demeanor. You should have open body language that's welcoming. Introduce yourself, your role, and the nature of the reason why that you're there and that is to help them. You can look at your patient at this point. Look at their nonverbal communication. Are they looking distressed? Do they appear sick? What kind of body language are they exhibiting? Are they aggressive? Utilize appropriate empathy towards these people and have their condition to develop a rapport with them. You can identify if there's any cultural preferences towards the patient, their condition, and if there's any gender pronouns or name preferences at this point in time. When you address your patient, you want to use some active listening skills. You want to provide a readback for the patient of the impertinent and the important things that they have said to ensure that they understand that you understand what they have given you and shared with you. Allow the patient time to answer your questions. Sometimes people take a while to answer you or they need to formulate their answer. If you're not getting the feedback that you are anticipating, you can always ask it in a different way. You could ask open or closed questions. That would be an example of tell me more about that, or do you sleep with more pillows lately, as examples of open or closed questioning. You should use appropriate language for the age and the cognitive ability of your patient, and that just keeps an open communication and a good line of understanding. With regards to your history, you want to get an incident and a medical history. You can determine through questioning whether they have an acute issue, a chronic issue, or an acute on chronic issue. Do their signs and symptoms present a recognizable collection that we can create a differential diagnosis from? What is their social history? Do they do any illicit drugs, alcohol, tobacco, etc.? What other medications do they take with regards to prescriptions? Are they compliant with their medications? Have they had any difficulty taking them recently? Obtain a medical history as much as you can from patients, and then of course any allergies they might have. Utilizing a mnemonic-like sample, which would be signs and symptoms, allergies, medications, past medical history, last oral intake, or events leading up to, can help you to keep all of this in order and in a fashion that you can remember easily. Your physical exam, you should always gain consent from your patient before you examine them or touch them. You should inform the patient of what you're doing so that they understand that you are going to physically touch them and look at their body. Explain your procedures and informing them gives them a sense of involvement in their care, and it could potentially also reduce their anxiety. When we approach the patient, we're looking through ABCD mnemonic, which is airway, breathing, circulation, and of course defibrillation. We can also do what's called AVPU, which is alert, verbal stimuli, painful stimulus, and unconscious, which will be a level of consciousness assessment on our patient when we first arrive in. We can look at them. Do they pass the look test? Do they look sick? Is there a life threat that I can immediately recognize? You're going to assess the patient's level of awareness. Obviously, you can use AVPU, or just speaking to them, you can glean a Glasgow Coma scale associated with that as well. Taking a quick look at their skin as you're touching them to get a pulse, radial pulse. Is it skin dry? Is it normal? Is it diaphoretic? Is it pale? You can glean some quick insights into their condition just by looking at skin. You can palpate both carotid and radial pulses for rate, rhythm, and quality, and equality of all of those as well. As you're looking at your patient, you can see their work of breathing with regards to their respiratory rate, using any accessory muscles. Do you hear audible adventitious sounds even without auscultation? And basically, do they have any issues with speaking? So this patient in particular had 3 to 4 word dyspnea, so they had some level of distress. You can look at further circulatory status. Is the patient actively bleeding? Are they cyanotic, mottled, flushed? Do they appear to have being incontinent? That's another thing you can look for with regards to urine or bowel. Is there any obvious deformity, trauma, or edema? That's as you're doing your quick body assessment with your initials there. You're going to assess, obviously, their vital signs. Do you want to do their heart rate, blood pressure, oxygen saturation, respiratory rate, and temperature? If it's applicable, you can obviously check a blood glucose, which is a point-of-care device that we all use as paramedics. Note all over their body if there's any implanted medical devices, if there's scars from any medical procedures or self-harm. That would be like pacemakers or dialysis ports, implanted glucose monitors, or Foley catheters. Ensure that these sites are clear of infection or any defect as well. You can assess the patient in your initial contact for any sort of odors. So you would look for ketones, solvents, and any sort of gastrointestinal bleeding. That's a specific smell that we all tend to be able to recognize with some experience. When you find abnormal findings, explain them to your patient. You can reassure them that if body systems that they have concerns about are found to be within normal limits as per your assessment, and you should also discuss the limitations of your assessment findings as well. Doing a focused assessment on a specific body system, so you would go back and readdress any of those issues with regards to, so this would be a specific respiratory versus cardiac assessment that we would do, so it would help us to further establish a working differential diagnosis, and we could work through those through a focused assessment. Do any of the body systems relate to each other? Are there any that may develop signs and symptoms that will overlap with regards to your assessment of them, so you can rule in or rule out? Obviously, we're going to use the diagnostics that we have. In this case, we did a blood glucose as a point-of-care device for this patient. We also did a 12-lead ECG to rule in and rule out an ST elevation infarction or anything different with regards to planes and hearts of the heart and axis deviation. And we would also utilize an iStat on this patient. Other point-of-care devices that are available to EMS are also ultrasounds. So once you've done your assessments, you're going to develop a treatment plan for your patient. So you've gone through your differentials and you've narrowed it down to maybe one or two that are signs and symptoms that you have tools in your toolbox to treat. You're going to obviously obtain consent, ensure that your patient meets all the requirements as per the guidelines for indications and contraindications, and explain both the benefits and the side effects to your patient prior to administering them, and also have a discussion point about the time frame of when these medications should start helping them or to take effect. Once you've delivered your treatment, obviously you're going to do a reassessment. That includes a full set of vital signs and then a body systems assessment to see how your treatment has happened and if there's any change in your patient's condition. You're going to make a transport decision at some point. So obviously if you're making treatments on your patient, you're highly likely to recommend that your patient is going to come to the hospital with you. There are some instances where patients may refuse or want to refuse transport to the hospital. And of course, you'll have to explain all the risk benefits associated with that, as well as your assessment findings and any sort of limitations associated with your findings that may have the patient make an informed decision based on this evidence. You're obviously going to transport your patient, if you're to transport your patient in an appropriate device to do so, whether you need to use extrication devices or any other equipment that accounts for the patient condition. Obviously you're taking into account your patient's condition and that you can continue to safely and appropriately deliver treatment for them. Obviously, you're still going to continue to ensure that you have assessments are continual with your patient, and that you're keeping in mind any sort of clinical course or projected clinical course with regards to your treatment. So that might change how you start an IV, where you start it, whether you need a large bore, anything like that would assist in treating your patient at the hospital. So that's my assessment on a respiratory patient, and thank you for watching.